I'll just introduce Helen. You've probably seen Helen in previous tutorials, I imagine.
Yeah. Yeah. Hi, Helen.
Uh, Helen and I work together. One of the reasons for the switch to the Mondays is to make sure that we can kind of co-host and make it a little bit more sustainable. So like when I'm on holidays or Helen's on holidays, there's still kind of a backup.
Oh, fabulous.
So Helen is going to be providing like I guess the clinical application of stuff because Helen still works half GP, half as a sonographer. And she's just had a medicine memberships, I should say. So she's going to kind of make everything a bit more clinically applicable to sort of general practice and the sort of cases that you might see. Yes,
Great.
Simone? So the topic today is large airway disease. Now, as everybody knows, there's a kind of like almost a continuum between upper airway disease, lower airway disease, excuse me, and then pulmonary parenchymal disease to a certain extent. So the next topic is actually pulmonary parenchymal, mediastinal, and pleural diseases, which is actually quite big. So I am happy to kind of just stretch this out into like wherever we get to subject wise. But is there anything in particular you guys want to cover disease wise? Not really.
Not particularly. Pretty happy to go through it.
Yeah.
Yeah.
Just see where the wind takes us. Helen, do you have anything that you're particularly interested in?
I think decision making around like chronic cough, how far to push diagnostics and when to be happy that, maybe like a pred trial is reasonable or a cough suppressant trial is reasonable, I think would be interesting to cover.
Yeah. Okay.
How far we need to go ruling out other things.
Yeah. Awesome. Okay, so let's start with what constitutes the large airways?
The bronchi and the bronchioles and the trachea.
Yeah, trachea as well. Yeah, I think bronchioles are kind of stretching into lower airway, are they?
Yeah, probably actually. Yeah.
Yeah. I think it's the airway.
Large would just be the trachea and bronchioles.
Yeah.
Bronchi.
Yeah, yeah, exactly. So where the kind of this cutoff is in my mind where that cutoff is, and there might be different references on that, different resources. So I don't know that for sure, but that's kind of where I think of it. So when we think of our kind of damn-it, let's just make a little differential list of the type of diseases that we can get in those large airways. So D.
Degenerative.
Yeah, right.
Like dynamic airway disease or tracheal collapsing.
Yeah, great. That's pretty much the only degenerative one I call. I'm going to put the other one in anomalous. So we'll go to A. Can you think of any breed-specific tracheal abnormality?
Tracheal hypoplasia.
Yeah, good.
Like Boas.
Yeah. Did you say Boas?
Yeah, that would be breed specific.
Yeah. Is there a tracheal component to Boas?
Yeah, they get little tiny.
Hypoplasia. Yeah.
Yeah.
Yeah. So there's breed-specific hypoplasia. I mean, it is in brachycephalics. You're right. So it's part of that spectrum disorder. Any others?
Whoever's talking, it's really hard to hear you.
Is it me?
Yeah, actually, Anna Jess just put in a comment as well that he can't hear you very well. I don't know if you can come.
Okay, let me just double check my microphone. Is that any better?
That's
Oh,
better.
that's better.
Okay, cool. I just turned my volume up. So there's a breed specific malformation of the trachea. which often doesn't affect, they're born with it, but it doesn't affect the dogs till later in life. Does anybody know what that might be? Little tiny dogs we don't see very often in Australia.
Well, collapsing trachea in lay terms, but
Yep.
it can affect the bronchi as well.
It definitely can affect the bronchi. There's actually a malformation which results in Yorkshire Terriers specifically having like a
Heart
this
shaped.
shape, yeah, trachea. So the whole dorsal membrane is like they're born with this kind of W-shaped trachea sort of thing. I'll see if I can find a picture of it. But what often happens, because Yorkies also get concurrent tracheal collapse that they're often diagnosed with very young, but they've also got this concurrent like malformation, which actually makes them really poor candidates for stents.
Oh,
So it's an important one to screen for kind of prior to prior to stenting. So a lot of places will put tracheal stents in under radiographic guidance without bronchoscopy. Like if they've kind of documented tracheal collapse, they'll put a stent in. But I would, in a Yorkie specifically, I would always just do a scope, make sure we recommend doing a scope rather than sending to a facility that does just under radiographs.
There's something else I've seen, Anna, on bronchoscopy is I remember it in a Rottweiler at least, where the tracheal membrane was just basically hanging into the lumen down the worst of them, a third of the way, and that causes chronic irritation.
Yeah, absolutely. Yeah. So that's kind of tracheal collapse where it's just kind of so weakened, that cartilage is so weakened that it just kind of flattens right in. And yes, sometimes
Just the membrane hanging down, like in a straight.
that might have been, was that a Yorkie?
No, I remember it in a Rottweiler.
Oh,
It was some sort of working Rottweiler too, I think.
Right. So we'll get into this, but like the kind of pathophysiology of progression of tracheal degeneration and how damaging cough can be to tracheal collapse and like perpetuating that is, but what we may be seeing is the effects of chronic cough in that dog. And because the cartilage kind of weakens, so the cartilage kind of sits like this and the ligament sits down like that, it does look like it's just kind of the ligament collapsing down sometimes on scope. Excellent. So we've got degenerative, we've got anomalous. What
What's
about?
something like ciliary dyskinesia? Would that be a large airway disease?
Yeah, for sure. Absolutely. So what is ciliary dyskinesia?
Immobile cilia, or they don't work properly.
Yeah, exactly. Yeah. So now, can someone explain to me the mucociliary clearance mechanism?
The escalator of cilia that take all the crap out of your lungs.
Yeah. So it's very normal, obviously, to inhale stuff from the environment. So little bits of dust, little particles, there's going to be bacteria coming from your mouth and stuff, little bits of saliva and stuff like that will get down into those kind of, probably right down into the lower airways at times. And there's this continual movement of mucus and stuff that's kind of produced in the lower airways or that gets down there accidentally. The mucus traps it and then it's just escalated right up to the larynx where we then swallow it just completely subconsciously. So if there are many different things that can impact function of the mucociliary clearance mechanism, escalator, but ciliary dyskinesia is one that they're born with. So it's a genetic abnormality, which means that those cilia don't function very well. So they either move in a really disordered fashion or they don't move at all. So you can imagine then all of the mucus that's produced in the lower airways stays in the lower airways unless you can cough it up or get it to a point where the cough receptors can kind of help with that situation. Whereabouts are the cough receptors?
in the large airways.
Yeah. So the lowest cough receptor is actually at the tracheal bifurcation. So if you've got stuff in the lower airways, it's actually very rare for that to cause a cough in itself. Whereas in the upper airways, you really rely on that mucociliary clearance to get it to the tracheal bifurcation, and then you can actually bring it up. But coughing doesn't really work for lower airways unless that stuff is actually being escalated up into the higher airways where it can be brought up. And that's where physio and things become so important in a lot of these patients. So we can help them shake the stuff out of the lower airways and bring it up to a point where they can actually then cough it up.
How do we explain then dogs that have a cough when they've got cardiac disease that are pressing on the bronchi?
So it is pushing on the bronchi, isn't it?
Yes.
Yeah. And so if you think about like where the trachea bifurcates relative to where the left atrium is pushing up, it's right on the cough receptor.
Right.
So it's right at that bifurcation. And it tends to favor slightly left side. But if you think about Jeff, can you remember your anatomy practice or your postmortems where you're cutting through the trachea, you're cutting through the bronchi?
No.
No, you can't remember it?
They happened too long ago.
So I've heard somebody explain this, which I found very like tactile, and I could really relate to it. But if you can ever remember snipping through a bronchus or a trachea, and like the scissors are like going snip, 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 it's rigid, like it's really hard. A healthy bronchi and trachea, there's absolutely no way that the 30 millimeters of mercury pressure, or like, even if the pressure in the left atrium gets up to 60 millimeters, there's no way it's going to squash a healthy bronchus. So you're not going to cause a cough in a dog that's got heart disease with healthy bronchi. So where this is tricky and where there's an overlap of those two syndromes is myxomatous mitral valve disease is a degeneration of the cartilage in the valve. Dogs that have genetic predisposition to cartilage degeneration in the valve will very likely have cartilage degeneration in their airways as well. So when we get an increased pressure in that left atrium and a floppy bronchus, then all of a sudden we're getting the bronchial walls to touch each other and we're triggering that cough receptor. Can you picture it, like the rigidity of those airways normally?
Mm-hmm.
So if a dog is coughing with heart disease, it's actually airway disease, typically.
Do you think we should ever say that coughing is a clinical sign of mitral valve disease?
I think we can very safely say it can be a clinical sign in dogs with current airway disease and left atriomegaly.
Okay.
That's what I would say.
Yeah.
Yeah. So the left atriomegaly can be triggering cough in those patients.
Yeah.
But I would say we shouldn't say, and there's a paper now to show that pulmonary edema is not a cause of cough.
Yeah.
Yeah. But increased left atrial pressure is. So what happens, and we're going to pathophysiology of heart disease is coming up in the next few weeks, so we don't want to go too much in depth. But as we get increased mitral regurgitation, we get increased atrial size. Now that's not the atrium getting increase in pressure. It's actually the atrium growing to accommodate a bigger volume in response to very slight increases in pressure. So the atrial pressure stays stable as far as we can measure it, right up until they go into failure. So that tipping point between stage B2 and C. So all of a sudden the rate of regurgitation exceeds the rate that the atrium can grow to accommodate that. So left atrium is already enlarged, and then the pressure goes up in that left atrium, so it can't get any bigger, and then that pressure backs up into the pulmonary veins. So that's the kind of sequence of events. So that atrium should be just as soft and kind of should just bend around a normal healthy bronchus until pressure goes up, and then all of a sudden it's going to put a little bit more pressure on that floppy bronchus and it's going to potentially cause cough. So that's where we might get a bit of a correlation between B2 to C transition in heart failure and coughing in dogs. But it's not the pulmonary edema.
Yeah, but I think it's an important point to keep highlighting to owners, because we've all had the owners where their dogs, their little, like little small white fluffy breeds keep coughing and they keep smashing them with furosemide.
No. Yeah. Owners and vets, like I feel like those owners didn't come up with that solution on their own.
Yeah.
And that's a fairly new development in our understanding of heart failure, I think. We used to say heart failure causes cough for sure when I went through uni, and probably the first
me
like 5 years of my career, I reckon.
I found it quite easy to redirect everyone to the sleeping respiratory rate. Just redirect, redirect, redirect.
Yes, the most sensitive marker of progression from B2 to C is respiratory rate. It's
Give
better
them,
to go
give them
for-
something to do.
Yes, totally. But then they've got like the dogs who are also Cushingoid, and there's always those dogs
Yeah.
that are really hard. And cats. Cats are impossible. They purr every time you look at them. Excellent, good. So we've gone a little bit off topic. So anomalous ciliary dyskinesia. That's where what we were talking about. So ciliary dyskinesia. What interesting congenital abnormality is ciliary dyskinesia associated with?
When your organs are the wrong way.
Situs inversus.
Hmm?
Situs inversus. Yeah. So it's not, you can't rule out ciliary dyskinesia on the organs being the right way around, but they are often present simultaneously.
The problem is if they don't have that, it's really hard to diagnose ciliary dyskinesia if they're no longer an entire male. So
Oh yeah.
if they're an entire male, then you can look at the
Yes.
how the sperm move. But
I've never had a case, but I have heard about a case where it was diagnosed on tracheal biopsy.
how often are people doing that?
Oh, I
Sounds-
know. Yeah.
Sounds scary.
Oh,
Can
we
I just loop,
we
can I
have
just
to-
loop back to the entire male comment? What's the association with the entire male? This
Or you
sounds
can just look at their sperm, and if they're not moving, then they've got ciliary dyskinesia. Yeah,
okay.
yeah.
Sorry, I missed that, Simone. What was that?
So if they're an entire male, you just collect a sperm sample, and if they're not moving properly, then they've probably got ciliary dyskinesia. So there's like a direct link between, I don't know, the tail of the sperm and the ciliary stuff.
Okay. That's handy to know.
Yeah, it is. Yeah, it would be handy if we saw more entire males, I think.
Can clinically, oh, sorry, Annie, go on.
No, no. Well, I think the two dogs I've suspected could have this were both puppies with like recurrent pneumonia, so you might catch them before they're done.
Interesting.
Yeah.
And
Um,
does getting a diagnosis of that change what you can do clinically for them?
Not that I know of.
Just manage.
I guess it would be prognostically. I'd probably,
Okay.
I guess, be a little bit pessimistic with the clients.
Yeah.
Yeah, and it just gives you, I suppose, a reason to stop looking for another
Breathing.
like weird infectious cause of their recurrent
Yeah.
pneumonia or
Mm,
That makes sense. Yeah.
yeah.
mm.
Interesting.
Okay, so we got up to M, metabolic. Any?
Mm,
I can't think of any.
no, I don't think so.
N?
Is hyper A connected with that? Because hyper A dogs will cough. Why is that?
That's a very interesting point. So what effect does cortisol excess have on cartilage?
Oh, it calcifies it.
Yeah, and it weakens it actually. Makes everything, they get like really lax in the joints on cortisol.
Yeah, they do their cruise shit all the time.
Yes, exactly. Yeah. So the cortisol will actually cause like floppiness of the cartilage, so it will exacerbate any tracheal collapse that's present. And then the other thing is that it decreases the tidal volume by so much for several reasons. One, they're panting often. Two, their liver is enlarged and pushing on the diaphragm, so that the strength that they need to breathe is higher. Three, they can't build strength, so they actually lose diaphragm strength because they're in a catabolic state with the cortisol. They can't build like that diaphragm muscle, so they lose strength there despite needing more. So their tidal volume goes down a lot. which shouldn't necessarily cause coughing, but it's one of the factors that contributes to the panting, I think.
Mm.
One clinician, which many people know, proposes that one of the causes of respiratory changes in dogs with Cushing's is pulmonary thromboemboli, multiple tiny pulmonary thromboemboli, little clots going to their lungs, and VQ mismatch. And people with PTE, pulmonary thromboemboli, cough actually as a clinical sign. So that might be a factor as well, but we can't really prove it. Very interesting. Good question. So N.
You could have neoplasia. You could have like a chondrosarcoma of your trachea or something. Uncommon, but
Yeah. What about cats? What would be most common in cats?
squamous cell carcinoma.
Yeah, good. Yeah. It's not often like laryngeal. I've never seen one further down. I'm sure they can happen further down. I don't know if there are squamous cells in the airways. I don't think there are.
Oh, okay.
I think there
trachea. I've no idea why. That would make sense then.
because we've got columnar epithelial cells rather than squamous cells in those airways. Is that correct? Yeah.
Sounds correct.
Yeah, because they've got to have the cilia on them. They can't be the flat cells. What else in cats? And dogs, actually. Neoplasia-wise.
Oh, go back. Hi.
Sorry,
You've been sad.
I'm sorry, I'm just on a Zoom call at the moment.
Lungworm.
Oh, hang on, it's still on neoplasia.
Oh, sorry.
That's right.
I don't know. I feel like you're going towards lymphoma, but I haven't seen
I
it.
feel like lymphoma too, because that's just a cat thing.
I
Yeah.
am going towards lymphoma. Yeah, so I've actually seen both a dog and a cat with tracheal lymphoma.
Yeah, right.
So there's lymphoid follicles right throughout the airways, so you can in theory get lymphoma anywhere. Gosh, I wonder. I'm not going to be able to pull up the radiograph easily, but it was the most distinctive kind of tracheal neoplasia radiograph because it's like surrounded by air, and you just had this like trachea.
Okay, so it was like in the lumen.
In the lumen, yeah. And when we went in with a scope, that's where we actually took some biopsies of that as well and got a diagnosis that way. But it was almost completely occluding the lumen. In a little terrier and a cat.
I just Googled the type. This isn't me, this is Google. Well, it's a paper, but isn't this interesting? This is only 19 cases, but the average survival time was less than 1 month.
Well, I guess they're partially obstructed by the time they're diagnosed, right?
Awful. Even with 16 lymphoma, 3 carcinoma.
Oh, right. That's the other one we should talk about, carcinoma. Yeah.
Carcinoma. Interesting.
Interesting that.
That sounds like a very poor prognosis, doesn't it?
I wonder what, because I guess they're not surgical, are they?
This attempted a fluoroscopic guided debulking procedure, but resulted in a pneumothorax and hemothorax, and the cat was euthanized. Oh, that's not very good outcome.
No.
Not surgical.
I won't try that one. Yeah.
No, like debulking has been attempted, pred basically.
Yeah.
Yeah.
Interesting. Okay. Lungworm, Jeff said.
There's also another parasite, and I can't remember which one.
Is it called
that
like
forms nodules
cysticercosis? Sorry.
in the trachea, I think.
Cysticercosis?
That's what I was thinking.
Oh gosh. Challenging my parasitology now.
Isn't that the one they get from pigs? It's like the pork.
I think so.
Cysticercosis. Yeah, pork tapeworm. Yeah.
Vague memory.
Yeah, I've not seen it in an animal.
For some reason I've got the idea that they go into the esophagus rather than the
That might be right. That might be right. Because and then there's often a cancer that results. That could well be right.
Is there something called a tracheal worm? That's like in my head. Why is that in my head?
I
don't think we have it here.
definitely airway worm, like lungworms. I don't know about
Oh, no, it's in birds. Don't worry, ignore me.
in what? Birds.
Birds.
Oh, gapeworm?
Yeah, well done.
Yeah.
Good memory.
Yeah.
Zingimus trachea, wasn't it? The bird one.
Yes, yes. Well
Yeah.
done, Jeff. Yes.
Spirocerca is the esophageal one.
That's what I was thinking of.
Yeah. Okay. So good worms, lungworms. Probably never see it, but what other infectious, inflammatory, immune mediated?
That would be quite a lot of them because you could include
Mhm.
canine infectious tracheobronchitis, your upper
Mhm.
airways, so like your kind of standard kennel cough
Yeah.
complex, like your bordertellas, parainfluenzas, mycoplasmas,
Yeah.
infectious.
Excellent.
Heartworm
Yeah.
include. And then I guess like if you were suspicious of a true allergic reaction, like a hypersensitivity from that rather than just like an irritant cough, that would be classed as immune mediated.
Good. And what species would we say that's actually a really common presentation for?
Cats,
Yeah,
like
exactly.
their feline asthma.
Yeah, exactly. Yep. So allergic etiology, inflammatory disease. Yeah.
Or dogs with eosinophilic airway disease.
Yeah, good. Which part, upper airways, lower airways, do we typically
Well,
see?
is it a bit of a spectrum with like I've seen one that had a horrific pneumonia, so I suppose I put
Mm,
that in the lower airways, but
yeah. Most of the time, particularly the eosinophilic diseases are in the pulmonary parenchyma.
okay.
Eosinophilic bronchitis is much more common in cats than in dogs. So they're much more susceptible to aeroallergens and then the bronchoconstriction and stuff. Sequelae of that. So asthma is a really big one, topic-wise, which I don't actually know whether we cover that on its own. Like it should have its own chapter, surely. But I haven't seen it. Anyway, what about where we have overlap of degenerative and inflammatory disease in a dog?
I mean, I think it's super common to see chronic bronchitis overlapped with dynamic airway disease.
Yes, totally. Yeah.
I feel like most dogs that have one have the other.
Yeah, absolutely. And cats for that matter. There's this kind of spectrum between asthma and chronic bronchitis, isn't there? Different kind of mechanisms, but actually kind of similar. I mean,
But
cats
less of the dynamic, like less of the actual degeneration of the cartilage in
in
cats.
cats.
Yeah, like
So
how much
the
do you
lungs
recommend
have,
that?
the lungs have very few ways of dealing with inflammation. So what happens as you get inflammation of particularly the mucosal layer, is you get replacement of those columnar cells which have the cilia associated with them with essentially fibrosis. And then we get squamous cells actually over the top of like fibrous tissue. So chronic inflammation leads to loss of mucociliary mechanism, escalator mechanism. You lose that the ciliated cells. They're not very good at replacing themselves if the inflammation's been that bad for that long. So in all animals, that's one of the only ways the airways have of resolving themselves. Now, so in dogs, we get airway collapse, causing narrowing of the upper airways. In cats, we get bronchoconstriction or tracheal constriction, airway constriction, causing narrowing of the upper airway. So in both cases, we get a resistance to expiration. And in coughing patients, if we kind of think about what forces would be impacting those lower airways, like lower than where the obstruction is. So if you generate enough force to cough and you're coughing against a pretty closed airway, you blow out the bottom of your airway, which is weaker. So that's kind of where we get this continuum of kind of upper respiratory tract and lower respiratory tract disease, and where we get chronic bronchitis and then recurrent pneumonias and things like that in these patients that have obstructive pulmonary disease, whether it's asthma or like degenerative collapse. And then we get inflammation, we get scarring, loss of mucociliary clearance, and then infections. So a lot of these like diseases, kind of the sequelae are the same, whether it was a worm that started it or asthma that started it or degenerative process that started it. Sometimes we end up treating them really similarly. So yes, the kind of, I guess that's the way I think of that spectrum between degenerative or inflammatory diseases and then development of chronic bronchitis. Excuse me. There was one actually, it's not really relevant. I was going to say one congenital thing we didn't talk about. That's like tracheal malformations associated with persistent aortic arches. So typically we see persistent right aortic arches, which compress the esophagus, but actually there's a bunch of other aortic arches. I think there's 6 that can actually cause narrowing of the trachea, and you can just get kind of single rings of hypoplasia, which typically, because they're still rigid, cause like a hypoplastic trachea kind of symptoms, but not actually any clinical signs as far as coughing and stuff go. So I think for me, it would make sense to kind of say all of these things can potentially cause cough, and then the sequelae of cough is chronic inflammatory disease. So therefore, how do we work out where on the spectrum of that disease these patients are, and how are we going to manage them based on etiology, and then where on that spectrum they are? Are they chronic bronchitis, and does it matter what the etiology was? Helen, did you have any cases you wanted to?
I think, yeah, I think it would be interesting if everyone agrees to kind of go through your approach to chronic coughing, where for example, like small dogs with murmurs, often get an echo, but a very early stage B1, for example. But sometimes it's obvious when you feel like you would need a BAL to work to, you're really worried about a bronchopneumonia, really, neutrophilia, pyrexia, high CRP, for example, or we were talking recently about an interesting case I'd had of a dog that had eosinophilic bronchopneumopathy, and its peripheral eosinophils were 18. So obviously it gives you like a marker, and its CRP was up. It was really distant. It gives you a marker to go and think a BAL might be really necessary. But I think it'd be interesting to go over kind of decision making where you don't have a really strong marker like that, how far we push versus how so many of these patients likely have chronic bronchitis, and at what point just managing that is appropriate with low dose pred, cough suppressants versus a full workup.
Yeah. It's such an interesting question, because the more we look, the more we find, and we sort of say almost the time it's the spectrum between like dynamic airway disease and chronic bronchitis, by far the most common thing we see, or asthma and chronic bronchitis. But now that the CT is becoming more available, more common, cheaper, they're like finding little like chunks of dry food in dogs' lungs and stuff. Like the incidence of aspirated foreign bodies reported like as a cause of chronic bronchitis or focal pneumonia is going up like exponentially. And it's not because it's happening more commonly, it's just because we're now looking more commonly. So I would say any patient that presents with chronic coughing, you could probably say to the client, look, it's almost certainly going to be this somewhere on this spectrum of disease. But if it is something that's potentially resolvable, so for example, like a focal foreign body or something like that, where you can take out the lung lobe and cure the dog for the rest of their life, particularly if they're young dogs, then I would say that the risk of not looking outweighs the risk of looking, and therefore that I would recommend that in most dogs.
Yeah, that makes sense.
I don't think we get enough information from radiographs to warrant that being the only test we do. So I don't think we can kind of say to clients, No evidence of pneumonia on a radiograph.
So it raises the question of the utility of radiographs in like
Yeah.
in a dog who is well and has a chronic cough, like different if they're unwell.
Yeah, for
But
sure.
I don't know. Yeah.
And how often do we actually catch tracheal collapse? Like we can't rule out pneumonia, we can't rule out tracheal collapse, we can't rule out focal foreign body. And we can't. So what information are we getting apart from like if there's a raging aspiration pneumonia or a huge pulmonary mass causing this?
Yeah.
That's what I'm looking for, but I actually can't rule out anything, and therefore I probably would say to people go straight to CT if it's accessible and affordable, and if they don't have any kind of barriers to that. I probably like I guess I would potentially do radiographs, but prep the owners that this is like a screening test that is going to like tell us whether we need to go to CT or not.
Yeah, that reminds me, I've seen two bronchial foreign bodies. One was in Riverston, and on X-ray there was sort of collapse of one lung, like I can't remember the term, with the lung lobe didn't have air in it. Sorry?
A lobar sign on the radiographs.
Yeah, anyway, something just made me do a bronchoscopy, and I pulled out a piece of Christmas tree.
Cheeky.
And the other one was in Wagga. We got I don't remember if there was an X-ray or what it looked like or a CT, but I pulled out a wheat seed head from it. That's the picture that in Martin Coombs' article about grass seeds.
And I think we've all seen dogs who've like scoffed stuff, like because like they were eating something, found something delicious, and the owner's approaching them, and they're like, no, these dogs aspirate stuff all the time, and we're diagnosing it more and more.
I have seen my dog cough other kibble. I am certain that she
it was
coughed other kibble. It was moderately alarming.
Yeah, I actually had a Chihuahua with like a huge fragment of pig's ear. Like it would have got stuck in the esophagus if it had gone down the esophagus, but it was in the trachea.
God.
It was absolutely massive. I don't know how it got there. It was a very unwell dog. Quite a blue. Anyway, we got it out. It's fine. What were we talking about? Oh, well, yeah, diagnostic process. So CT just helps you rule out all of those like less common things, and also shows you where you need to look. So you can then be quite targeted if you've got unilateral or like focal lung change. You can do your BAL targeted in that section. So often what we do is CT, have it interpreted while the dog's still under, and then go straight to bronchoscopy if it's indicated, and be quite targeted in what we're looking for or what we're doing on bronchoscopy. Most of the time, what we see, particularly on CT when it's kind of dynamic airway disease, is like little bully and things, and like we were talking about that concept of like the lower airways kind of being blown out, and that particularly when it's diffuse, we can sort of say, okay, there's like been diffuse airway collapse or asthma, which has resulted in, it's in humans, it's called chronic obstructive pulmonary disease. And it's that sequelae of chronic bronchitis and pneumonia secondary to that obstruction. Do we see airway collapse on CT?
I would have thought it was the same as radiographs, like you're lucky if you see it, but
yeah, exactly.
Unless you do a dynamic study.
Yeah, exactly. So then if we're going to bronchoscopy anyway, how is bronchoscopy as a modality for diagnosing collapse?
Oh, excellent, I would have said. In my hands, anyway.
You can see it. Interestingly, these are coffee dogs, and it is very normal for airways to collapse to around 50% during coughing. So when we're doing a bronchoscopy, often what we're doing is like tapping the cough receptors at the tracheal bifurcation and then watching what happens. And there is actually a big overlap between dogs that have tracheal collapse and actually cartilage degeneration and dogs that have just been coughing for a really long time. Interestingly, inflammation causes temporary cartilage degeneration, so it can actually be regenerated in these dogs that don't have congenital cartilage degeneration. So if they've had really chronic airway inflammation, you will see quite a big collapse, which isn't necessarily irreversible if you were going to fix the inflammation. So you might end up overdiagnosing tracheal collapse or lower airway collapse or bronchial collapse in these patients. So fluoroscopy, conscious fluoroscopy is the best way to diagnose airway collapse. It's got limitations in that it's not as good for bronchi because it's harder. They sit over the top of each other and you can't sort of say it's left and right and stuff. And you've got to do it from a lateral aspect because most dogs are collapsing top to bottom rather than side to side, but you should do both because they can collapse both ways. So say we've got a dog that has like the trachea is just like floppy. So we've got primary tracheal collapse as our cause of cough in the dog. And we've diagnosed that on fluoroscopy. What are our treatment options for that patient?
Medical management
Yeah.
or an intraluminal stent.
Yes, exactly. Yeah. So what's our medical management? What's our kind of like sequence of meds that you're going to use?
Put them on a weight loss diet if they're a little fat thing.
Oh, great.
It's
Yeah.
yeah.
Very good.
I
It's
follow
so
with
important, actually.
yeah.
Yeah.
Manage inflammation, so using inhaled or systemic, if they can handle it, steroids, but trying to use a lower dose because, like we spoke about, the cortisone will weaken cartilage. So
Yes.
just anti-inflammatory doses.
Exactly. So in these ones with primary collapse and the inflammation is secondary to the cough, I reach for that really far down the track because I don't want to exacerbate the collapse, which is going to exacerbate the cough, which is going to exacerbate the inflammation, even though like by treating the inflammation sort of thing. So that's kind of one of my last resorts in these guys.
So cough suppressants.
Yes, thank you. That's the key because it's the cough that's causing the inflammation in these ones.
Yeah.
So if we can stop them from coughing, weight loss, massive, absolutely massive. That's a really good call. But then cough suppressants, whatever we can do to get these guys to cough less. Does anyone have an objective goal that they kind of say to clients, I want them coughing less than this many times a day? Because it's rare that we get them to stop coughing completely.
No, I often feel like I use the owner's tolerance, but that's probably not very good because owners is so variable of what they're tolerant of.
Yeah.
I don't know, there probably is some sort of a cough scoring system that we should be using.
I haven't seen one.
Oh, okay.
Yeah.
What's your cutoff?
Say again, Helen.
What do you like to get them down to?
I usually say less than 4 times per 24 hours. And I usually say to them, if they're coughing, I don't want them coughing more than kind of 3 times in a fit sort of thing. So they can kind of go, but I don't want them to cough for 30 seconds, you know?
Wow, that would be a drastic reduction for
A lot of patients.
yeah.
Yeah.
Can I ask what antitussives people are using or find the most success with?
Mm-hmm.
When I worked in England a long time ago, you could get butorphanol tablets, and I managed quite successfully a few dogs on butorphanol tablets and low-dose ACP tablets. But then you couldn't get butorphanol tablets. That was in England. So that was the end of that.
That would have been good. I personally think, you get the dog in to do procedures, you give it some Torb, and the owner's like, for the next 8 hours, the dog's the best it's ever been.
So good. Exactly. Yeah.
I definitely think 12 is exceptionally effective. Yeah.
I have had patients that I've just had come in every second day for a 12 shot.
Seriously.
Yeah,
Wow.
it lasts so long.
I mean, I send home owners with buprenorphine. I suppose we could send them home with butorphanol if they can give it subcut more.
And why not, right?
Yeah, maybe not. Yeah.
Yeah. And they definitely don't need it. Like butorphanol will last a lot longer as a cough suppressant
Yes.
as a sedation.
Yeah. Yeah.
They definitely don't need it more than like once a day, I don't reckon. So codeine is the one we have available, I think, in that class. There's another one that they use in the US. I think it's hydrocodone,
I think so.
which we don't have access to here. Which New York, the AMC team that do all the stenting and stuff like that, they're like, what do you mean you don't have hydrocodone? Like that's the only one that works. Codeine doesn't work at all. So if that ever becomes available, like that's kind of the one that they think works the best. But codeine's kind of all we've got for the moment. What other, has anybody got any other kind of things that seem to work for cough suppression?
We've had a couple of dogs we've tried meropenem in.
Yeah, I've tried to, but what did you think, Helen? I don't think it worked.
No, not really. I have to say, I'd love your decision making on this, Anna, but I've definitely had dogs where I feel like no cough suppressants work, and I've had to use like 0.5 mg per kg pred a day. I don't know if I'm reaching for it too early though. And then I feel like if they've had that for a couple of weeks and then we try taking it away, the cough suppressants are more effective.
Yeah, that makes sense.
Down that cycle, yeah.
Is anyone worried about the possibility of a secondary infection when they're reaching for cough suppressants up front? Like, does anyone do 2 weeks of doxy or something before putting these guys on cough suppressants? It's probably irresponsible use of antibiotics.
Yes.
I think it's a good point because I wonder if when we were talking about the decision making in general practice, let's say you have a client with a chronic cough and they have definitively declined CT, bronchoscopy, fluoroscopy, which would be absolutely ideal. Like, do you think there's any benefit for these chronic but well dogs with chronic coughs to, if you have them in for thoracic radiographs, telling the owners, these are our limitations of that, but doing a little BAL if you've got them intubated anyway at the time? I feel like that's not something we do that often in general practice, but maybe would be a good step for not reaching.
Yeah, tracheal wash. I mean, I don't know why it's not done more in general practice.
Yeah.
I mean, I didn't do it in general practice either, but I now I look back and I'm like, why not? It would have provided heaps of useful information.
Yeah.
Yeah, my experience with that is quite often I've done BALs, or so I thought, and I've got more results off the end of the endotracheal tube than I have out of the wash. And
So I guess how do we interpret that information that we're getting from an airway wash? So if it's eosinophilic, it was amazingly useful. If you get like lungworms in there, amazingly useful. If you get like pneumocystis or something like that, amazingly useful. But if you culture positive in the presence of a neutrophilic inflammation,
are people culturing? I wouldn't culture. I'd just do cytology.
yeah,
Just basically make the decision for empirical antibiotics based on if you've got degenerate neutrophils or if it looks really sterile.
yeah.
And like a kind of boring mixed, because most of these chronic dogs are going to be neutrophilic, but with some eosinophils as well, right? From the chronic, would that be right? Yeah. So like, but very sterile looking.
And with not very many cells. Like the inflammation is not a huge component of primary collapsing trachea or bronchi more so, but primary collapsing trachea, they're often younger dogs, like 6, 7 kind of thing. And this is where history, like when you're kind of saying to clients, when they decline diagnostics, you can kind of say to them, okay, tell me the character of the cough, tell me when they're coughing. How would, when they're coughing and the character of the cough, help you differentiate from, like, infections typically lower airway? There's not really that many chronic infections of the upper airway. So how would the character of the cough and the timing help you differentiate or like screen for infection?
Yes, infection could be like wetter, like less dry sounding and productive. and maybe more continuous rather than triggered by excitement or exercising, for example.
Yeah. So upper respiratory, or like, I shouldn't say upper respiratory, sorry, tracheal or bronchial collapse is typically on excitement or exertion. Whereas an infection cough is typically when the mucus is kind of settled.
Yeah, so like when they're waking up overnight, that type of thing.
Yeah, exactly. Yeah. So the
Yeah, although I
time,
do sometimes wonder about like temperature change in all these dogs that cough overnight, because that's, when all dogs like to cough. Yeah, like whether temperature change is just an irritant or something.
yeah. So I don't reckon the primary like tracheal collapse dogs where there's no secondary infection or secondary bronchitis, I don't think they cough overnight.
Okay, interesting.
They're the ones that cough when you press on their throat or when they're like excited on a walk, when the owner gets home. It's very much on excitement, but as we said, there's this continuum between upper or tracheal collapse, bronchial collapse, and then bronchitis. So then we get, if they're coughing all the time on excitement and overnight, they've got chronic bronchitis almost certainly. And that's when you can like kind of, I guess, decide, okay, well, if they're coughing overnight, I think it's probably prudent to do a trial, an antibiotic trial with your pred. But if they're only coughing on exertion, I would be quite confident with obviously no neutrophilia, no CRP elevation. I would be quite confident to just reach for codeine in this situation.
And if you were going to do an antibiotic trial, Anna, would you do doxycycline, and how long would you do it for?
I would do doxycycline unless they're neutrophilic, unwell, or if there's been like an acute change in the character of the cough, and that's what prompted the client to come in. I'd probably only do it for a week.
Okay.
Yeah. I don't think we have good research to support doing it for longer than that. And what are we using doxycycline for in these patients?
It's well, it tends to localize in the lungs better than a lot of other antibiotics.
Yeah, it's got good penetration into the bronchi.
Yeah.
What else does it do?
The mycoplasmas and so forth are more susceptible.
Good, excellent. So mycoplasma cyanos is like the like actual pathogenic infection that forms part of that upper respiratory tract infectious disease complex. And typically they're pretty sick with that. So they've often got a fever, they're lethargic, it's quite acute onset and stuff like that. So we're not prescribing doxycycline to treat a really kind of pathogenic mycoplasmal infection. We're using doxycycline to reduce bacterial load, which might be exacerbating inflammation or irritation in the airway. But these are commensals. As soon as we stop, they're going to come back. It's not like we're trying to clear an infection. So the protocols I'd use in this situation are different from the protocols I'd use to clear a pathogenic mycoplasmal infection. And it's just giving us enough time, like Helen said, like the pred, to get our cough suppressants and underlying factors why we might get kind of, I guess, dysbiosis in the airway or more bacteria getting into the airway.
Yeah.
Do we have any, like, I suppose in my head I've always got like, if they had, a severe dysbiosis or a bit of an infectious component, and then we give them cough suppressants, like they could get worse. But like, do we have any evidence of that?
They'd have to have a really bad pneumonia to get
okay.
worse with the cough suppressants,
Okay.
given how ineffective our cough suppressants are.
Yeah, okay.
They'd have to get like have really, and hopefully clinically we can see that,
Yeah.
Between the history and the testing that we're allowed to do, we should be able to detect that. And I do think, cough suppression is the key to managing most of these patients, because the inflammation is from the cough. So if you sort of think about that, like collapsing of the airways every time they cough, the airways rubbing on itself, we're getting like ballooning and scarring in those lower airways, we're exacerbating that mucociliary damage and perpetuating this kind of cycle of disease. So cough suppression is the thing that stops that inflammatory kind of cascade from developing. So as much as we can do on that front is.
Yeah, that makes sense.
So then other questions. When do we reach for a stent?
When they are going into proper respiratory distress from their tracheal
Yeah.
collapse.
Yeah. And it's the
Before
last.
failing medical management.
Yeah. Yeah, exactly. And often it's the young patients with the like quite kind of good long-term prognosis if we can manage their cough. What are if you did sort of recommend a stent, what are the outcomes? What can we prepare clients to expect?
They will keep coughing. In fact, they'll probably cough more.
Yes, good. Yeah. But
They won't die and become cyanotic, hopefully.
yeah, exactly. Yeah.
And go
So
into
they're less likely to get those like wheezy cyanotic events of like pure respiratory distress. Less likely to be hospitalized as a result of the disease. So it is a last resort. They're still coughing. We still need to manage the inflammation associated with cough, but we do get less inflammation because the trachea is not collapsing in on itself. Stent itself causes some inflammation.
Yeah, I think I listened to a webinar or something once, and the whoever was placing the stents was like, if he won't do it if they can't give inhaled glucocorticoids because just reckons the rate of complications is too high. So if it's like a a bitey dog or whatever, and the owners can't do that, then he just won't do it. Yeah,
that's probably a good screening test actually. Yeah, it's not. Yeah, I think people sort of think, oh yeah, I'm just going to hold the trachea open. It's a quick fix, but it's not.
Do they get high rates of secondary infections as well?
Yes, and particularly when they've got that tracheal malformation or if the stent isn't quite big enough. So if you've got this like W-shaped trachea, they there's like a gutter, they call it. So it kind of sits like there and then that part becomes infected and they just get, it's yuck. Yeah, the scopes, the videos of the scopes for those dogs are so rank.
Yeah, I just imagine like pulling a stent out afterwards, it's just covered in gunky, pussy mucus.
well, you can't take them out though, right?
No, but I mean like on post-mortem. I just
Oh
imagine
yeah, okay.
being like, oh, I don't know why.
I mean, I think they kind of get pretty quickly like the tissue grows over them like
Yeah, that's true. Yeah.
quite quickly, right? I think, yeah.
And even once they're deployed, like the degree of trauma that you cause scraping that out of the trachea, like even before they've kind of grown in. So what they do typically, if they've like inflated a stent in a dog and then they go down and confirm it bronchoscopically, and if they can see that there's a gutter there, they actually balloon the inside of the stent. So they push the like trachea around, and then they like will often like wreck the stents kind of. It compromises the like structural integrity of the stent by doing that, but it's lower risk than the gutter.
Yeah, that makes sense.
Interesting.
I've never done one, but they freak me out a bit.
Oh, I just you could refer to a paper by Dengate et al. On bronchial stenting, where we put a bronchial stent in a dog and expanded it in the left bronchus and compressed his left atrium, decreased his left atrial volume quite substantially, and tipped him into like the worst congestive heart failure I've ever seen. He was on a ventilator for 3 days. And they went ahead with it and he actually went on to do quite well, but yeah, it was
That sounds stressful.
quite a like unforeseen complication of the procedure.
Yeah, no kidding. Gee, that's crazy.
Yeah. All right, everyone, we might wrap up. We didn't get to tracheal trauma, but I think that's okay.
This is medicine. We don't have to talk about trauma.
No, exactly.
Those foreign bodies, that would be trauma. Pig's ear.
Yes, yeah, you're exactly right, actually. Yeah. And then scope trauma, like iatrogenic trauma. Okay, so next topic is pulmonary parenchymal vascular and pleural disease. So if anyone's got any cases they want to talk about, let us know.
In 2 weeks, I believe it's a public holiday.
Oh yes, this is the 9th of the 2nd.
Wow, okay, cool.
Yeah, far away.
Okay.
Good spotting, thank you.
So, Anna, are we doing Mondays now and not Fridays?
Mondays from now on. Yeah.
Okay.
Yeah. So every second Monday, apart from when it's a public holiday. Then
Which unfortunately there are a few Mondays, but anyway.
that's true, actually. Yeah. We'll
But I
see.
like Mondays.
Yeah. Happy?
Yeah.
Yeah. This works a lot better for us. Yeah.
Perfect.
Amazing. All right. Thanks, team.
Thank you.
Bye. Thanks, Anna. See you guys.
See you soon.